Hello everyone. In this video we will talk about opioids, and like all other pharma videos, the video notes of this lecture are available for free download from the app. So what are opioids? Opioids are chemicals which are used basically for analgesia for pharmacotherapy, and these chemicals cause analgesia without loss of consciousness. However, these opioids are also present as natural ligands in the body for certain receptors, that is mu receptor, delta receptor and kappa receptor, and these natural ligands which are present in the body, these are known as endogenous opioids. So broadly, these endogenous opioids consist of three different types of chemicals, that is endorphins. Endorphins, now it is a term which is commonly used to denote to all endogenous opioids, but that is not so. Endorphins themselves, they are a different set of chemicals. So we have endomorphins. Endomorphins has M, it acts on mu receptors. Then we have enkephalin, which acts on delta receptor, and dynorphins, which act on kappa receptor. So these are the main receptors. That means these chemicals have the maximum affinity for these receptors. However, they can act on other receptors as well, but they have the maximum affinity for these receptors. Okay, so I told you endomorphin has M, which acts on mu receptor, but here you see enkephalin has K, but it doesn't act on kappa receptor. It is delta receptor, and dynorphin has D, and it doesn't act on delta receptor. It acts on kappa receptor. So that is also a kind of mnemonic, that D doesn't act on D and enkephalin K doesn't act on K. Maximum affinity for enkephalins is for delta receptor. Then we have endorphins. Endorphins act equally on mu receptors and delta receptors. Then for understanding this action of the opioids, we should know endogenous descending analgesia system. So in detail, this system I have discussed in my video on pain physiology, that if you want you can check it out, but we will in short see it here. So here this purple lines which you are seeing, this is anterolateral spinothalamic tract, which basically carries pain and temperature. Okay, and this arises from A delta and C fibers. So this is the first order neuron, and in the spinal cord, in the ventral horn, it is making contact with the second order neuron. So there is a synapse. Now you see at this junction where first order neuron is making contact with the second order neuron, there are certain influences from the top. So we have periaqueductal gray matter, which makes connections with the rostroventral medial medulla, and from here again it is making contact, this black one, this is an interneuron. So periaqueductal gray matter releases enkephalins. Then from RBMM there is release of serotonin, which acts on the interneuron, and again this interneuron makes contact here at the synapse, and again there is release of enkephalin. So we see that at two places enkephalin is being released, and by the release of this enkephalin, actually this first order neuron cannot conduct the impulses to the second order neuron. So these impulses are going to be blocked. So impulses, if they are not carried to the central nervous system, there will not be any perception of pain, and hence this will cause analgesia. So this enkephalin, yes, this is endogenous opioids, but our pharmacology, they also act like that. How? So we have this periaqueductal gray matter. This release of enkephalin from periaqueductal gray matter is under inhibitory control of another neuron, that is secreting GABA. Now, when we administer opioids from outside, they inhibit the release of this GABA, so that there is more activity in this endogenous descending analgesic system, so that PAG is able to release enkephalin and activate this analgesic system, right? So that is one. Second is at this level where this is the first order neuron which I was talking, which is coming from your A alpha, A delta and C fibers, and it is making contact with the second order neuron in the spinal cord. Okay, so here also this is the interneuron which is activated by a descending analgesic pathway. So here also opioids are acting, and you see there are receptors for these opioids on this presynaptic neuron, right? So if we administer opioids from outside also, they will act on these receptors which are present on the presynaptic neurons, and by this they decrease the release of the neurotransmitters from this first order neuron. So this glutamate and substance P, their release is going to decrease. So how are they acting? Basically these receptors, our all basically all your mu, kappa, delta, all opioid receptors are G protein coupled receptors, and they inhibit the adenyl cyclase because they are GI type. They inhibit adenyl cyclase. This causes decrease in the production of CAMP, and this opens potassium channels. So here potassium channels are going to open, and if potassium channels open, potassium starts moving out, and if potassium moves out, it leads to hyperpolarization. So because of this, there is decreased release of glutamate and substance P. It also leads to decreased opening of calcium channels. So if calcium channels open less, so they are not opening, that means calcium will not be able to enter into the presynaptic neuron, and we know that calcium is very important for the fusion of the vesicles. So here vesicles are there which are containing the neurotransmitters, so they are not going to fuse with the presynaptic neuron, and there will not be any release of this glutamate and substance P. So if neurotransmitters are not released, there will not be any transmission of the impulse from the first order neuron to the second order neuron, and that sensation of pain will not reach to the cortex. The impulse is not going to reach to the cortex, and the person is not going to feel the pain. Okay, so these are two mechanisms by which our opioids act, and even the pharmacological ones which we give, they act by the same mechanism. Here at the periaqueductal gray matter, basically they are activating this endogenous descending analgesic system. They are also inhibiting the transmission of the impulse at the first order neuron level. Right. In fact, there are certain actions in the cortex as well which decrease the perception of pain. Okay. So, this we have discussed that it decreases the release of substance P and glutamate, and this leads to analgesia, and obviously activation of the periaqueductal gray matter causing release of enkephalins. So, that decreases the perception of the pain. But remember, here we are talking that it only decreases the perception of the pain. It does not affect the cause of the disease, because there are many diseases which may not be treatable. So in that case, we need to decrease the pain. So that is known as palliative care. Second, even during the course of the treatment, the pain is so much that the person's life will be miserable. So we need to decrease the pain during the course of the treatment as well. Okay, but remember, this opioids do not affect the cause of the disease, right? Now, apart from decreasing the release of these neurotransmitters, they also decrease the release of other neurotransmitters, that is, decrease the release of norepinephrine and decrease the release of GABA in mesocorticolimbic system. Okay, so that is also happening. So because of decrease in norepinephrine, obviously there will be decrease in the sympathetic activity, and this is going to lead to meiosis. However, meiosis, basically meiosis is what? Meiosis is constriction of the pupil. This is also because of increased activity of parasympathetic nervous system. But here, just for the sake of remembering, we are seeing, okay, actually there is a Dengar-Westphal nucleus, and there is increased activity, increased parasympathetic activity, which leads to meiosis, that is constriction of pupil. But because of decrease in norepinephrine, there is decrease in anxiety. There is also sedation, because our cortex, if in the cortex there is decrease in norepinephrine activity, this leads to sedation. Then decreased GABA in mesocorticolimbic system. Because of this, there is increased dopamine release in nucleus accumbens. Now, this nucleus accumbens is a very important component of the limbic system, and this dopamine release is under control of GABA, that is the inhibitory neurotransmitter. So if GABA release is decreased, that means there will be increase in the release of the dopamine. We are removing that inhibitory control, so there is increased dopamine release. This leads to a condition which is euphoria. That means there will be extreme pleasurable feeling which the person is going to feel, that is euphoria. Okay, but this also causes, because of decrease in GABA activity, this is also pro-convulsant. That means it is increasing the chances of seizures. Okay, now Coming to receptors with actions, because when we talk about pharmacology, we will see that there are certain drugs which act on certain receptors more than the other receptors, or drugs which act in a combination of the receptors. Okay, so we should know something about these receptors. So I told you before that we have mu receptors, kappa receptors and delta receptors. Now, just remember this mnemonic cramps. Okay, actually you can remember it as cramps here, cramps. Okay, C for constipation, R for respiratory depression, A for analgesia, M for meiosis, P for this physical and psychological dependence, and S for sedation. So these are the major uh, actions which occur when the mu receptor is stimulated, that is cramps. Okay, now this physical and psychological dependence occurs because of the condition euphoria, which I told you before, that the person has euphoric feeling, extreme pleasantness is there, he will have a pleasurable sense of well-being, and because of this has the person develops a drug seeking behavior. That means to achieve that he will want the drug again and again. Not only that, we will see later that there is something known as withdrawal phenomena, where if he doesn't take the drug, then he will start having withdrawal symptoms, and later on he seeks the drug to avoid the appearance of those withdrawal symptoms. So initially he starts taking the drug to get that euphoric feeling. Later on they become addicted. There is physical and psychological dependence, because when the drug is not present, then they get withdrawal symptoms. So to avoid those withdrawal symptoms, there is drug seeking behavior. So that is mu receptor, easy to remember, cramps. Dysphoria, again you remember same cramps, but P is not there. That's why I had written euphoria above, because the kappa receptor stimulation leads to dysphoria instead of euphoria. So that means that the drugs which stimulate mainly the kappa receptor, there will hardly be any dependence with these drugs, and dysphoria means that it is not a good feeling at all, and that is because the stimulation of the kappa receptors leads to decrease in dopamine release. Okay, so you can remember it as D cramps, and along with dysphoria there is diaphoresis as well, that is extreme sweating is there. Then delta receptor, you remember cramps, but with C you remember that there is increased, too much increased pro-convulsant action. So there is convulsant action here also, okay, but with delta receptor this is too much. And A, here you see I have written analgesia, and actually pain, you see there is one the sensory component of pain where you actually feel the pain, but pain also has affective component. Affective component is basically the emotions which are associated with the pain. Whenever pain is there, patient feels lot of distress. So stimulation of these delta receptors actually has analgesia, plus it lowers this affective component. That means the distress is going to go down. That is more. It is there with the stimulation of mu receptors as well, but with delta receptors, affective component reduction is much more. Okay, so that was about the receptors. Now, what are the opioid drugs? Well, we classify opioid drugs into three main classes. One is pure opioid agonist, then we have complex acting opioids, and finally we have opioid antagonists. In this video, we will talk mainly about the pure opioid agonist, and that too taking morphine as the prototype drug. Okay, so these pure opioid agonists, as the term indicates, agonist, that means they are going to stimulate the receptor. And till date, all pure opioid agonists are actually the ones which act on mu receptors. We have pure opioid agonists only for the drugs which are stimulating the mu receptor. Complex acting opioids, we will see that they are agonist, antagonist, they are stimulating kappa receptor and all, that we are going to see in next video. Today we will talk about pure opioid agonist, and that too mainly morphine, which stimulates the mu receptors. And opioid antagonist, as the term indicates, it is antagonist, that means it is going to block the receptor and prevent the action of the opioids. So, how do we classify opioids agonists? Okay, so opioids agonists are classified as natural, semi-synthetic and synthetic. Natural, which are naturally derived from the plants, we have 5 drugs: morphine, codeine, thebaine, papaverine and noscapine. Among this, thebaine, papaverine and noscapine do not have any analgesic action, so they are non-analgesic. Then in semi-synthetic, we have heroin and hydrocodone. Then synthetic, we have many drugs. We have pethidine, which is also known as meperidine. Then methadone. Then we have fentanyl and its analogs, fentanyl, ramifentanil, sufentanil. Then we have tramadol and tapentadol. So those are the drugs. Now you should know certain terms here, that is opiates and opioids. What is opiates? Opiate is any chemical which is derived from opium or which is chemically related to morphine. So any drug whose structure is similar to that of the morphine is known as opiate. On the other hand, opioids. Opioid is any drug whose action is similar to morphine. Okay, so opiates is for chemical structure or it is derived from opium. Opioids, on the other hand, it is related to function. Opioids are functionally similar. Okay, compounds with morphine-like action. So, now moving to the actions of the prototype drug morphine. Okay, so simple. You remember this mnemonic V cramps, and if you remember this, you will be able to tell its action. We will see its action in the opposite manner. So first we will talk about S, then P and then M, like that. Okay, so your mnemonic is V cramps. So first is S. S is that morphine causes sedation, that I have told you that it decreases the norepinephrine action. But remember, these drugs, even though they have central actions, but the receptors, the mu receptor, kappa delta receptors, they are present even peripherally throughout the body. So they have peripheral actions as well. So they have central actions and peripheral actions. So S for sedation. Then there is action on a smooth muscle as well. And what is the action? That is similar to that of the sympathetic system. That means it relaxes the longitudinal muscle and contracts the circular muscle. So relaxation of the longitudinal muscle and contraction of the circular muscle, it will affect certain functions in the various viscera. For example, in GIT, this will lead to constipation. In genitourinary system, it will lead to urinary retention because the sphincter is contracted. Then it also leads to spasm of the sphincter of the Oddi. Sphincter of Oddi present at the junction of the biliary duct with the duodenum. Okay, so that contraction also occurs, and this is the reason that morphine should not be given in undiagnosed abdominal pain. Morphine is contraindicated as analgesic in undiagnosed abdominal pain. Why? Because this abdominal pain can occur due to biliary colic. It can occur due to biliary colic. Now, if you give this morphine, biliary colic pain is too much, and if you give morphine, then what will happen? There will be further spasm of sphincter of Oddi and the pain is going to increase. Okay, in fact, the condition itself is going to worsen. Okay, so that is why morphine is contraindicated in undiagnosed abdominal pain. Then it relaxes longitudinal muscle, so it relaxes uterus as well. So it prolongs labor, but sometimes in labor, because of the concept of painless labor, morphine can be given also. It is used as well, right? Then P, as we have dealt, that is sedation. Smooth muscle, relaxes longitudinal muscle, contracts circular muscle. So because of that, we have constipation, urinary retention and sphincter of Oddi contraction, relaxation of the uterus. Then we have the physical and psychological dependence. That is because of the euphoria that occurs because of decrease in GABA release and increase in the dopamine release. That is, there is extreme pleasurable sensation, there is loss of apprehension, calming effect is there. Then M. M is for meiosis, that is constriction of the pupil. Then we have A. A is for analgesia, that we have seen mechanism of action, how analgesia is going to occur. So there is decrease in pain perception, but there is decrease in affective component also. That means the distress of the patient is going to decrease and this will lead to increased tolerance. So even if the pain is not completely eliminated, because the distress part, the affective component is decreasing, the person will feel increased tolerance towards the pain. But this does not happen with other analgesics like NSAIDs. It happens with opioids. Now, in pain perception also, opioids are more effective in certain kinds of pain. That means visceral pain is reduced more than that of the somatic pain, and nociceptive pain, that means the pain due to the stimulation of the receptors, is affected more than that of the neuropathic pain. Neuropathic means where the neurons themselves are damaged. In that case, opioids may not function that well. Okay, so visceral pain is reduced more than that of somatic pain. Nociceptive pain also is reduced more than the neural or neuropathic pain. Then A also for anti-anxiety, because it is decreasing the norepinephrine release, so there is anti-anxiety as well. Then we have R, that is the respiratory depression. So this opioids cause respiratory depression at higher doses, and that too mainly they decrease the carbon dioxide mediated drive of respiration. See, respiratory center is continuously stimulated depending on the oxygen concentration in the body and carbon dioxide concentration in the body. When oxygen is less and carbon dioxide is more, both are stimulating the respiratory center, and this is maintaining the respiratory drive depending on the requirements of the body. Now, this opioids depress mainly the carbon dioxide mediated drives. So, hypoxia which is there, it will maintain some drive for respiration, and this we will see that how it is important in morphine poisoning. Anyway, so yeah, carbon dioxide mediated drive is gone, and because of respiratory depression, there is increase in partial pressure of carbon dioxide. Carbon dioxide will not be thrown out of the body, so there is increase in partial pressure of carbon dioxide. This will lead to vasodilation, and mainly it affects the intracranial tension. Because of increased vasodilation in the cerebral vessels, there is increase in the hydrostatic pressure, and this leads to increase in intracranial tension. And that is the reason that morphine is also contraindicated in head injury, because head injury, there may be already blood vessel damage, leakage of the blood might be there, and this will lead to increased intracranial tension. Now with morphine, this increased intracranial tension is further increasing, and this will lead to compression of the neurons, right? So that is why morphine is contraindicated in head injury. Now here you are remembering that it is depressing the respiratory center, respiratory depression is there. So just remember here, it also depresses the vasomotor center, and vagal center is stimulated. So because of the depression of vasomotor center and stimulation of the vagal center, there is bradycardia. Then R for rigidity as well, that when you are giving in pharmacological doses, one of the side effects of morphine is truncal, that is chest wall rigidity. Then we have C. C is cough suppression. Cough suppression. So cough suppression occurs at doses much earlier than the dose which causes respiratory depression. So this is more sensitive factor. Cough suppression. In fact, in refractory cough, morphine can be used, and its analogs can also be used. It causes constipation, that we have already seen here, that smooth muscle relaxation, longitudinal muscle relaxation and contraction of the sphincters, it will lead to constipation. Then it also causes convulsions because of the decrease of GABA, right? Then the mnemonic was V cramps, right? So it also causes nausea and vomiting, that is by the direct stimulation of the chemoreceptor trigger zone. Okay. Now apart from this, there is also one another action, that is it releases histamine, right? And this release histamine causes vasodilation and decreases the blood pressure. So if morphine poisoning is there, excessive opioids are there, then it will lead to hypotension. Okay, hypotension. Also, histamine release causes bronchoconstriction. So, with respiratory depression and bronchoconstriction, that means morphine is contraindicated in asthma, COPD, or in conditions where there is reduced respiratory drive, right? So that was the actions of the morphine. So if you understand that, now further it becomes very easy. Okay, so what will be the uses? One is analgesia, we have already discussed. Remember that cramps, right? So V cramps. So analgesia is there, and it is used in cases of severe pain, that is traumatic pain, visceral pain, post-operative in case of burns, cancer pain, and it can be given IV also in case of emergency conditions. It can also be given in as epidural and intrathecal injections. Then it can be used in case of refractory cough, not given generally because it causes respiratory depression. So it is only given in cases of refractory cough, and in fact other drug is there, that is codeine, which is better given rather than morphine, but morphine also can be used. Then we have in case of refractory diarrhea, because we have seen that morphine is causing constipation. So in case of refractory diarrhea, morphine can be given. Then it is very important, it is given in case of myocardial infarction. So how is it related? Well, IV morphine when given in case of myocardial infarction, it decreases the pain and it also decreases the apprehension and anxiety, so that there is decrease in the sympathetic nervous system activation. Second, because morphine is releasing histamine and it is causing vasodilation, so this vasodilation is more in case of systemic vessels. Pulmonary vessels also dilate, systemic vessels also dilate. But because systemic vessels dilate more than the pulmonary vessels, fluid from the lungs can move into the systemic vessels. So it relieves the pulmonary edema. Okay, so these are the uses of morphine: analgesia, refractory cough, refractory diarrhea, and IV morphine in case of myocardial infarction. Now little bit, very little bit about pharmacokinetics we will touch, because what happens that this morphine can freely cross the placenta if given to mother, and I told you that in case of painless labor where it is required, there morphine is given. So because it freely crosses liver, fetus can be affected and this will lead to respiratory depression in fetus. So that means whenever morphine is used in mother, we should always be ready for respiratory depression in fetus. So we have to give opioid antagonist in this case. Basically it is given directly in the umbilical cord and we have to give so as to prevent this respiratory depression or treat this respiratory depression. So counteract the action of morphine. Now morphine, when it is being metabolized, it has two main metabolites: morphine 6 glucuronide, which is basically an active metabolite. So this can be an MCQ. Okay, so morphine is metabolized to morphine 6 glucuronide. So glucuron addition is taking place in liver and active metabolite is formed. Also morphine 3 glucuronide can be formed, which is neuroexcitatory. So that will promote the convulsions, right? So that was uses and pharmacokinetics. Coming to side effects, so we have already seen the actions as weak cramps. Okay, so one side effects obviously is vomiting. Then we have constipation, respiratory depression. If given in pregnancy, then it can cause respiratory depression in newborn, also known as apnea of newborn. There will be decrease in blood pressure because of vasomotor center depression and also release of histamine. Then there are high chances of physical and psychological dependence. Plus, there is tolerance. What is tolerance? Tolerance is when the drug is given over a period of time, then the dose of the drug required to treat a particular condition keeps on increasing. Okay, so that is tolerance. So suppose you are using certain dose for analgesia, after some time you have to increase the dose, and this occurs because of the desensitization of the receptors. Okay, so what happens that too much action of the opioids causes desensitization of the receptors and this decreases their action. So over a period of time more and more doses required, right? Now even for the euphoric action, the person who is seeking this drug for euphoria, for that also tolerance develops. So that means over time the person will need more and more drug for the same effect. Okay, and this ultimately can lead to opioid poisoning because of increased requirement of the drug, right? So that we are going to see little later. Now when tolerance occurs, cross tolerance to agonists of same receptors occur. So other drugs which are also agonists for the same receptor, that also cross tolerance occur. However, this cross tolerance is not complete. That means suppose you are giving opioid, say suppose you are giving morphine for analgesia, then there will be start of development of tolerance. So what we do that after some time we switch to some other drug. Okay, so use another drug, say suppose methadone you use. Okay, and then again after some time you switch back to morphine. So this is known as opioid rotation in pain therapy, so as to avoid the development of the tolerance, because the tolerance is not complete even though some cross tolerance is there. Then next side effect we have seen sedation. Others is truncal rigidity, okay, that we saw chest wall rigidity can occur. And another one is opioid induced hyperalgesia. Yes, opioid induced hyperalgesia, that is increased pain, can also occur. And this is because when opioids are given, we are seeing that it decreases the release of substance P and glutamate, okay. But what we see that there are certain compensatory mechanisms which start in the body which increase the release of this glutamate. So that now with the same stimulus there is increase in the pain. So this opioid induced hyperalgesia can also occur, right? Now, I told you with time, with people who are seeking this drug for euphoria, because of the development of tolerance, the requirement of the drug is going to increase and the person may land up in acute morphine poisoning, or they can be overdosed during treatment also, right? So, what are the features of acute morphine poisoning? Same cramps, just remember these alternate, okay, alternate words. There will be respiratory depression. So death due to respiratory failure can occur. Then very important sign, meiosis, okay, and then the person because of excessive sedation can land up in coma. Plus because of histamine release and depression of the vasomotor center, there will be hypotension. There can be hyporeflexia and temperature regulation is also affected, so it will be hypothermia. So you see all features are hypo. There is hypotension, hypoventilation, hyporeflexia, hypothermia, hypoconsciousness and meiosis, that is hypopupil diameter we can say, or meiosis. Easy to remember is meiosis, I guess. Okay, so that is acute morphine poisoning. Now what to do for acute morphine poisoning? We have to give opioid antagonist naloxone. So in detail about this drug we will see in the next video. Naloxone is the antidote for morphine poisoning, okay, that is given. Supportive treatment is given, that means we have to support airway, breathing and circulation. But remember, do not give oxygen without ventilator. Why? Because we have seen that respiratory depression in morphine poisoning occurs. Why? Because of the carbon dioxide driven response especially is affected. Now, hypoxia is the only respiratory drive which is there. Now, if you give oxygen without the ventilator, then that drive, respiratory drive of the patient will be gone. So, if you have to give oxygen, give with ventilator, because ventilator can cause the artificial respiratory drive. Okay, so that is you will be maintaining the pressures for the respiration. So, do not give oxygen without ventilator. Third is gastric lavage. Gastric lavage is done because morphine is a basic drug. So what happens? Say this is stomach, this is in the stomach, environment is acidic. Now from the blood vessels, the morphine will move. Morphine is lipid soluble, it can cross, right? So it will move here. Now, once it goes here in the acidic environment, it will be trapped here, because in the acidic environment, it will ionize. Understanding? So, basic drug ionizes less in basic environment. It will ionize more in the acidic environment, and that's why it will get trapped here. So once it is trapped here, you have to do the gastric lavage to remove the excess morphine, because if it goes into the stomach, it will move into the small intestine as well. And from the small intestine, the environment is basic. In the small intestine, pH is high, right? pH is more, the environment is basic. So from there, the morphine will be again reabsorbed back, because it will not ionize, it will go into non-ionized form, and the absorption is going to increase. So this concept we have already done in our video on pharmacokinetics, where we talked about ionization, non-ionization, trapping of, we took an example of aspirin, right? So, gastric lavage, even if the morphine poisoning is due to IV drug, gastric lavage is done in acute morphine poisoning, right? Then last component which we are going to discuss in this video is tolerance and dependence. So what is tolerance? Tolerance is, that means for the same effect more and more dose is required of the drug with time and receptors become desensitized. That is the main reason for tolerance. So same drug will not be able to act on the receptors. But tolerance doesn't occur to three main actions, that is constriction of pupil, convulsions and constipation. That means the addicts, they are like chronically constipated. If you look in their eyes, there will be meiosis and obviously there will be chances of convulsions. Now, because of the tolerance, this person for euphoria will seek more and more drug. Okay, and in fact, when the drug is not taken, it will lead to withdrawal symptoms. Why it is going to occur? See, here the drug is acting, okay, and say suppose it is causing decreased release of norepinephrine. Understanding? Now, tolerance has occurred, that means this receptor is not active. Now, norepinephrine will be released more when the drug is not present. Understanding? So, when the drug is not present, the baseline action which was there in the body, that is going to increase. Suppose opioids is decreasing GABA release, that means when opioid is not there, there will be automatic increased GABA release, and that is why the dopamine release itself will be less. So when the drug is not there, the person will feel dysphoric, he will not feel good. So there are certain withdrawal symptoms which occur, and this is known as dependence. That means to avoid the withdrawal symptoms, the person will take the drug. And what are these withdrawal symptoms? Yawning, lacrimation, sweating, mydriasis, anxiety, fear, like something doom is going to happening, palpitations, hyperalgesia. So very minimal stimulus will lead to pain, restlessness, tremor, aggression, all features of increase in sympathetic system and also increase in the motor system activity. Then there is diarrhea, increase in the blood pressure. So to avoid all these things, the person will take more morphine, and because of the tolerance, obviously the dose required will be more. Now, how to prevent the person from this behavior? Can we give opioid antagonist? No, we cannot give opioid antagonist. See, if you give opioid antagonist, it will block this opioid receptor. So basically, it is behaving like the drug is not there. If you give opioid antagonist to an addict, then it will precipitate the withdrawal symptoms. Okay, and it will increase the drug seeking behavior. The person will not be able to tolerate this. So instead of that, what is done? Withdraw morphine, replace with methadone. Okay, so we are giving another less potent drug in small doses, and then gradually we are decreasing the this dose of methadone. And this methadone is basically a long acting drug that we are going to see in next video, and because of this feature that it is long acting, it is given for treatment of addiction. Okay, so withdraw morphine, replace with methadone, and slowly with time withdraw methadone. That means keep on decreasing the dose of the methadone which you have given. Fine. So with time what will happen? The desensitization of the receptor which has happened, slowly it is going to reduce. The receptors again will become sensitized. Now, say maybe the person is off the drug now, not taking the drug, but if the person gets into that company of a person who is also a drug addict, then there are high chances that there will be relapse. The person will again start taking the drug. So in that case, you have to give opioid antagonist. So if a person again goes into drug seeking behavior, again he becomes addict, then you have to follow again this principle of giving methadone, gradually withdrawing methadone. And because now you know that there are high chances of relapse in this person, then you block the receptors with opioid antagonists, so that now if the person takes the drug, then the drug is not able to act on the system and there are no effects of euphoria seen with the opioids. Okay, so that is tolerance, dependence, and what you will do to prevent this drug seeking behavior in an addict, and if there is relapse. So that was about the prototype drug, that is morphine. Rest of the drugs we will see in the next video. Thanks for watching the video. If you liked it, do press the like button, do share the video with others, and don't forget to subscribe to the channel Physiology Open. Thank you.